Hello and welcome to our discussion today about assessment activities in care. If you haven't already, please be aware that we have a separate training where we go over these different points in care in which assessment activities can occur. This video is an open forum discussion, which means we're going to host a panel of individuals on the ground who are performing assessment activities on the ground, and they have different experiences that they can share with you. So let's go ahead and take a look at who will be joining this conversation. So we are joined by Amber Irvine from San Diego. She is a licensed marriage and family therapist who works with underserved and vulnerable populations, including working with chronically homeless and serious mentally ill adults as part of their assertive community treatment team. We're also joined by Jenna Bell, who is a mental health clinician for Yolo County, and she works in the forensics department of the Adult and Aging branch. She's new to Yolo County and began in October to be of service to the CARE program, and she's also done a lot of work serving individuals in that community. We're also joined by Kate Jones, who works with the Alameda County Behavioral Health Department. And she's the director of adult and older adult services in Alameda, and she's worked in Alameda to do a lot of systems change work, oversees the budget there, but she's also a registered nurse and experienced manager, and has led work within the county to better serve those in Alameda and support them. We're also joined by Kimberly Romero, who's joining us from Siskiyou. Kim is a supervisor for the Adult System of Care and Diversion and Care Court, and works in Siskiyou Behavioral Health Department to serve the populations there, and has done work with acute forensic populations since 2010. Nicole Ashalamov is a program manager for the Care Outreach and Engagement of FSP and Bay Area Community Services in Alameda County. Prior to that, she was a clinical supervisor for the HEAT FSP, and she's been working in community mental health for 16 years. So we're pleased to be joined by these panelists, and we'll now turn to that live discussion.
So what I'd like to do today is really thinking about care assessments in sort of a linear fashion is talk a little bit, following Rachel's lead, what they might look like when thinking about the initial petition, what assessments might look like when we move forward to other aspects of care. So I'm going to begin and ask our colleagues here, what kinds of internal processes or procedures have been put in place to assess people when you're thinking about a care petition? Maybe I could begin with Amber.
Great. Thank you so much, Deborah, and thank you for having me here. Happy to be here. So in San Diego County, our process for when we receive a referral or a petition is really the same, and that starts with an extensive review of any records that are available. Again, as has been mentioned, we really want to avoid not only duplicating efforts from our clinical team, but avoid what's often a re-traumatizing experience of asking these very structured assessment questions when really our primary focus from our care team is to build rapport. And oftentimes, the vast majority of individuals who have been referred or petitioned, they're not new to our system of care. And that's why they've ended up to this point where a care petition is being filed. So they've just, for one reason or another, struggled to connect to the resources and treatment services that are available to them. So there are generally a lot of records available to us where we can get at least the start of the clinical picture without having to kind of sit down in a formal setting and do a thorough structured assessment. The other thing that we do is we really start by building rapport with the petitioner, especially when they're family members or long-term treatment providers who don't believe that the individual is meeting their needs or in the correct level of care. family members are such a wonderful and valuable resource when it comes to building rapport and engaging individuals and to the sorts of assessing them. So we really ask very specific questions to family members about, again, with the primary focus on building rapport. Or what are some things that they really like? What are strategies that might help us engage with them? What are things that we want to avoid saying or approaching them in certain ways that might immediately make it more difficult for us to build that rapport? So our assessment really starts with those two pieces. And then from there, when we do our first initial outreach, it's really just about connecting on a human level. And the assessment is very much so clinical observations and picking up on nonverbal cues. We go out in teams of 2, usually, with an assigned clinician and a peer support specialist or a case management assistant. And our team is really looking for, again, not just assessing the individual, but assessing their environment. And so much can be learned and gathered through just observations rather than asking specific questions that might be off-putting to someone who has struggled to engage in treatment up to this point.
Thank you, Amber. And I see your colleagues are nodding. So I think there must be some similar experiences in the other counties. Nicole, Kate, can you tell us a little bit about how you're thinking about approaching assessments for petitions?
Yeah, you bet. The first thing that we do is at Behavioral Health, we receive and all of those court orders and petitions, and then we look them up. We look at their records, and then another thing that we do is we look up what's going on with all of their benefits. So SSDI, are they Medi-Cal connected? And we gather that information, and then along with all the court documents, we then send those over to BACS, who we contract with to do the outreach and engagement, the investigations, and they also run the FSP team. So we kept our outreach and engagement team and our FSP together so that they could work as seamlessly as possible in this process. So from there, I'll turn it over to Nicole to describe how they're approaching assessment.
Yeah, so I would say that the more information we get in our referral or a petition that is sent to us, the easier it is to do the assessment with the client. So it's unfortunate that someone has been in the system for so long, but that does tend to guarantee a little more information. And we do a thorough review of the referral before we go out to see them. From there, I would say that for the care assessment in particular, it's a lot less in-depth and clinically focused than, as you said, a behavioral health assessment. So we tend to rely a lot more on observational content and what goals they're expressing they want. So it's all about building rapport for us when we're doing that first assessment for care. Moving into the FSP, when we've built more rapport for that more clinical assessment, we do a more sort of thorough, like historical sort of background assessment that can be a little more traumatizing, as Amber pointed out. But that's also because we have built more rapport at that point. We want to keep it really, really focused on that relationship building early on. So it's really just about building that relationship and doing those initial contacts to get the information that we need to help them meet their goals while they move into FSP.
And, the last thing I'll say is just that we're very flexible. The court has been working beautifully with us on our timelines. We're really just meeting people where they're at. And some of you, I'm sure you know, some of our folks get destabilized in this process of coming into care court. So we're really just meeting them where they're at. And if necessary, extending those timelines for the investigations to be completed in a way that's meaningful. Yeah. So just to add that.
Yeah. So let me stay with the three of you for one moment before we bring Jenna and Kim in more. The question's been asked a lot, and you're talking about observations going into the community. What about folks who are hesitant to engage or who are not able to engage? How do you approach that assessment and that petition?
I can jump in here. in being Southern California and San Diego, we have coined the term engagement burritos. So sometimes that goes a long way. So again, just approaching someone on that human level of, hey, can I get you something to eat? Can I get you a cup of coffee? Just introducing yourself and assessing them. And we have people that walk away immediately, especially if you're coming up with like your county badge. Like we advise not approaching an individual from this like clinical and sort of government as that sort of person, and just a genuine human who's there to find out what you need and help you get there. But yes, we have people who walk away, but what we find is just with persistent engagement, and it might be 2 minutes, but for 5 days in a row, that they start to recognize us. They start to see, oh, this person isn't going away, even though I'm walking away. But doing that in a very gentle way where we, of course, want to honor their preferences, their rights. But we also want to continue to show up to show them that we care and that we're not going to just give up. So that's one of the approaches, and we've really found it very successful. We've have a wide range of the amount of time it takes to engage an individual. That I think we have one that it took 134 days of that outreach. And that seems extreme, but it is worth it if you can eventually build that rapport.
Mm-hmm. And Nicole, I'll ask you, are you able, and certainly Amber chime in, are you able to file petitions for somebody who has not engaged? What does that look like?
I think I need some clarity, because file petitions for someone who's not in. Once the petition is filed, it goes to us, and that's when we start going.
Okay, so then, right. So let me go. So let me ask it a little bit of a different way. How are you getting or collecting information? What are you documenting? And I'll ask this also maybe Amber, Kim, Kate. What are you documenting for the petition in that initial contact, if folks have been resistant or hesitant to engage with you?
Yeah, what we document is very, with a lot of clarity and detail, our initial outreach attempts and what that looks like, so we can come back together as a team to try to strategize for the next outreach attempt, right? Because what we're always doing with clients that are having trouble engaging is doing our best to come at it a different way, or just use that persistence that Amber was talking about to continue making that contact. Because my experience is similar to Amber's, where when our team does that initial engagement, if a person is hesitant, we'll show up again the next day and we'll try something new. Like if we brought food the first day and they didn't want that, we'll bring water. It's just, and that seems small, but some people who are living on the street are, they don't have an appetite. So food can seem a little bit revolting, especially when a stranger is walking up to you with it. Did people?
Yeah, not sure.
Oh,
Did we freeze?
Yeah, yes, a little, but we heard you.
Okay.
Oh, good.
Oh, good. Yeah. So it's really just about recognizing and having a lot of observational skills about what's going on with the client and adjusting to meet that client's needs. And I will say, for who goes into outreach and who goes into FSP, we're really trying to utilize people's strengths, especially because I think that's where they find the most joy in the work. So our outreach team tends to be people who are really good about just walking up to people and being like, hey, can I buy you some lunch? Or if someone says yeah, I don't need anything, you don't have to come back tomorrow. And they'll be like, cool, so I'll see you tomorrow. Because they just have that sort of attitude and they're really friendly and willing to go the extra distance.
And just one more thing to add, we're really focused on engaging folks on what they want. I think so many of our clients are so used to being engaged on what they need. We're taking the approach of what is it that you want? What would you like to work on to try and change the conversation? Because they've been here, done that for so many years, and it's been so focused on needs. Sometimes the best form of engagement is focusing with somebody who wants to get studio time, and that's exactly what's happening.
Interesting. I have a feeling we're gonna come back to talking about engagement frequently, because we know that that occurs throughout the care process. It's not just for the beginning, it's throughout. So I'm gonna put a pin on it. I want to shift a little bit, and I'll ask Kim and Jenna, when you're thinking about assessing either for the initial petition or later, do you have templates, materials that you use? How do you collect and document these things?
Sure, I can jump in. Oh, well, I'll go ahead and
No,
then
go
Kim
ahead, Jenna.
can follow me. Tara and I work in pairs. We are the two people. We don't have peer support workers or case managers at this point working with us. So we're kind of, doing this initial engagement together. And it's always better, if you don't know a client, to go in pairs if you can. But for our first types of engagement, I just want to mirror what everyone else has said so far, which is it's really about building rapport, making that connection. We've had luck bringing somebody coffee, and engaging them really at a human level. Sometimes it takes a couple visits, but one thing that we always document and observe is the person's mental status. That's really informative. And it's, what we document when we first meet a client. We don't try to get into any specific questions, really just want to get to know them at first. So our initial documentation tool really is the mental status exam. And then what we can observe, like what, how are they living? How is their personal care? That kind of thing.
Yeah, and I would agree. We don't have any current documents made specifically for our care activities so far. That being said, we haven't gotten very far in the process yet. We just had our first few petitions go through, so we are very new in the process. We do have all the documents from San Diego that I'm looking at now, adapting to our needs. Thank you so much for all of that. That's been helpful over these past few months as we started this. And I would echo, kind of everyone else that's already spoken as to how we engage these individuals. We here in Siskiyou are unique in that it is a big, vast county geographically. Excuse me. But our largest town is all of 7,000 people. Most of them are 500 to 1,000 people. So we are almost all intimately we're familiar with most of the people that are going to be referred through our care courts, whether they are coming through behavioral health or whether we just know them from our community, our church, wherever. So we are lucky that we do get a lot of collateral as these people are being identified. And we do meet with the public defenders, we meet with the sheriffs and police, while maintaining confidentiality, of course, but we're always open and receptive to their concerns about our clients or potential clients in our community and how we can best serve them. So I know they have also identified several people that they are in the process of petitioning. But yeah, and one thing that we're doing is we do have an identified case manager and clinician that can work with these individuals, but also just keeping them with their current treatment team if they're already in services, not rocking the boat, not making this a big life shift for those clients. We should be doing the background work. We should be the ones getting everything ready. This shouldn't impact the client's life a whole lot is really what our goal is, my goal is, because this is such a big change for a lot of people, but it doesn't have to be. We're really just hoping we can get these people involved in services and get them stable so that this is just a background program for them. This isn't something that dictates their lives or their treatment or prognosis or their future.
Yeah. And I think, Kate, you've also developed some tools based off of San Diego's to document assessments in these outreach efforts, correct?
Yeah, absolutely. Big thanks to San Diego. They sent us their templates a couple of months ago. We worked with our internal team to get those put into we're just giving a shout out to you, Amber, for sharing your templates. We had those added to our electronic health record. And then also the care administrative, we added that to billing. So we added that to our electronic health records so that BACs could just go in and be able to bill those administrative hours accordingly. So when writing agreements, investigation reports and whatnot. So
And
we
I'm
did just make
interrupting you. I apologize for that, but we are going to get to claiming because that is a question that's on the top of minds for a lot of people. So we will ask some
Sure.
detail
Now,
on that.
yeah, just one quick thing. We did add, we changed the format just a little bit for the investigation form and the agreement. We've actually created our own sort of summary sheet. So because the templates really are geared so much toward gathering the many data points that have to be reported to the state, we actually then came up with a one-page document for the investigation that summarizes it in one page, and then it's very clearly stated what the investigation is recommending. And then for the agreement, that's also a one-page, very simple document that has the plan on there, the steps to reach those goals, timeline, and then just the 3 signatures that are required in accordance with the statute. Boom, done. And the judge has a much easier time, as does the public defender, reading that document. And I would add the people that we're serving.
I appreciate that. And I am willing to bet that other counties right now are saying, I wonder if including YOLO, will ask, could we get a copy of that? And so give some thought to that. If there are documents for all of you, we have these great opportunities to learn from each other and to take the best. So if these are things that you're willing to share, please let us know and we can get them out to the counties who request them.
More than happy to.
Thank you. I think we might have lost Amber. I know that she's having some technical challenges, so I'm going to go on and we'll bring her back when we can.
I'm finally back. I apologize. Murphy's Law.
No need to apologize. You were getting a lot of love while you were out, and folks have been talking about using the tools and the templates that you've created to help create some of their own. So thank you. I'm glad that you're back.
Absolutely. And happy to share with other counties. Just reach out to me or your HMA liaison, and we're happy to share those.
Thanks, Amber. So let me continue to move forward. And I appreciate we're talking a lot about outreach and engagement because obviously that is crucial throughout the entire care process. But I want to think a little bit more about what that means as we go forward with court reports and investigations. And so this would be after the county is receiving the 105, is the court is informing the county that a petition has been filed by another entity. So, and I'll begin, Amber, since you're back, I'm going to just start with you. How do you structure that? Who goes to court and who does the reports?
Yeah, absolutely. So as I mentioned, we assign a clinician right the day that we receive that petition and the 105 from the court. And that engagement starts with that clinician and a peer support or case management. And that clinician is the author of the report, but really incorporating the feedback of the whole group and the peer support's perspective, the case management and various treatment providers, the petitioner. And so they are the author of the report. We have 3 program managers for care in San Diego, and they operate primarily as the court representative. But the way that we do that is we have a case conferencing meeting weekly with our clinical staff so that we're able to discuss not only all of the cases that are on calendar for that week, but also any difficult times we're having building rapport or locating individuals or finding strategies to connect with them or treatment recommendations. That's another thing. Although the eligibility criteria for care seems pretty straightforward, it's actually quite nuanced when individuals are open to treatment programs, but maybe it's not the right level of care or they're not really meaningfully engaging. Even if an individual is voluntarily willing to enter into an FSP, a sort of community treatment program, but we can see that there's a history of difficulty engaging with programs like that. That might be one of the reasons to move forward with care. So it's really very nuanced, but in terms of the court representation, we do have, everybody is really aware of all of the cases through that the clinical meeting that we have, which we also then have a meeting with the public defender, and then a meeting with our county contracted FSP provider that's actually providing the care services. So all of that happens on Tuesdays, so that when we go into court on Wednesdays, everybody knows pretty much what's going to happen. We're all on the same page, and it's very streamlined.
How about some others? Kate, Nicole, I'll ask you.
Yes. So, I'm sorry. Can you repeat the question? I was listening to her process and I forgot where we started.
That's even better. So my question, and I'm going to add to it a little bit now, is how do you staff this up for reports for court appearances?
Sure.
And I'm going to add to it, which is also then how do you help prepare clients for that?
Interesting question. Yeah. So I would say currently we are still working on building our team. My ideal would be that I'm sending one case manager or care coordinator and one clinician. That's what I want to work towards. But currently we only have one clinician, so I can't really make that happen yet. So basically the way that we're doing it, because we have a lot more care coordinators at the moment, we're generally sending out 2 care coordinators or our clinician and a care coordinator to go interact with the client initially. And then as we start to sort of meet with them and build rapport, me or my supervisor or the clinician that I mentioned will go meet with the client and like collect observations and gather collateral from the team and things of that nature, and then start to build, the investigation report. As we move the person to FSP, right now, whoever they started with is usually who they will be moving over with, because we haven't separated our teams yet, because we just don't have enough people to do it. But eventually it will be that they will get a warm handoff from one team to the next, and then we'll continue to have one clinician and one care coordinator.
And then furthermore, when we staff court, first off, we meet with BACS twice a week. That's on Tuesdays and Fridays. And then we meet separately with our public defender twice a week. That's on Mondays and Wednesdays. And then we have care court, everyone together on Thursdays. So we are literally meeting 5 days a week in some way, shape, or form about care court. And I would say right now it's still necessary to meet 5 days a week. Yeah. We've been growing rapidly. So the other thing is that I myself have been in attendance. We have a new senior program specialist, so I've been attending and representing the behavioral health department. We have our county council there, our public defender. BACS sends anywhere between 2 and 3 people on a weekly basis. Yeah. So Nicole is there as the program manager, and then a clinician, and then the staff bring folks in directly, or they'll appear by Zoom. And then, of course, we have Judge Bean. So that's really how we're staffing it as well.
Yeah, and in terms of prepping the client, I will say that it really is tailored to the client. Like, some people are eager to come to court, and it's easy once we talk to them about, they're just like, yes, I want help, please help me. And like, I would love to talk to the judge. And then for people who are more reluctant, we're going to spend a lot of time talking to them about the process and thinking about introducing them to the PD, and ask for extensions if we have to, because it's not going to work if we're not going to advocate for that time.
Thank you.
And if
I'm sorry. Go ahead, Amber.
Sorry, I just wanted to add something that you made me think of. But the other piece that I failed to mention was that we also have at least one clinician who attends court every week, because sometimes we have many matters set and there's people waiting in the hallway, and they really operate as like a triage clinician, where we can, instead of having a calendar that's like set, we go in order of how they're numbered. It's, this person's starting to become very anxious, and they're, presenting like I said, with anxiety, or that we can then move their matter up and have them heard, just to really make sure that everybody is comfortable and can be seen in the most logical order. And similar to what Kate and Nicole are sharing, we also offer virtual attendance, but always allow it to be the respondent or participant's choice. If their preference is to attend in person, we will coordinate that transportation and support. And if it's virtual, we will still support them and have staff there with them virtually.
Really expanding person-centered services to not only what's in a care agreement or a care plan, but to their experience with the court as well. Kim, Jenna, anything that you want to add to that we might have missed? Things that you're doing differently?
You guys have it all very well covered. Again, we're very new in the process. Again, with our population, we just don't have as many petitions coming in, so we haven't gotten very far. But I can tell you, we are definitely taking note of other counties and their successes and the tips and tricks. So thank you all for sharing.
I guess for us, the one thing I would emphasize is that it is so important to meet with the client more than once before writing that report, because especially with schizophrenia spectrum, people might have a good day or a bad day. They might be, really clear one day and, not clear another day, really symptomatic. And, we have had an experience where we didn't think the person really was going to be able to handle being at court. And then there they were. They showed up on their own. And that was a surprise to us. And so, and we've had other clients who we've interacted with, and then, they'll leave a very clear message on the phone where it wasn't even clear if they were using a phone. So it's just been really enlightening for us to be able to meet with clients more than once, because it's really going to, been able to give us a bigger scope, a bigger picture, a clearer picture of really what that person's experiencing day to day, and not just in one piece of time.
That's a great point. And that's that ongoing engagement that we've talked about happening throughout care. So I'm going to go back now to something, Kate, that you said, and I'll ask the team, maybe Kim, I'll start with you, is when we think about claiming for these activities, have you tapped into your EHR? What kind of things are you thinking about? You're kind of newer to this, and it's helpful to hear. Certainly other counties will appreciate that. How are you considering claiming and documenting and then submitting claims?
Sure. I think the training that we received first off was great. So we're categorizing whether these activities can even be claimed if they're billable. I think one of the things for us is, for everyone, is keeping track of the times that we're spending on all the different care activities that we're doing, because they do blur together so much. Reporting blurs together with outreach, blurs together with notice, blurs together. So keeping those times distinct and separate so we can both document and claim appropriately. And again, I think as we get further into our process, building our EHR out so that we can properly claim and bill for all the services that we are providing, because there is a lot of work that goes into even just preparing a petition. Even before the petition is submitted, there's a lot of work that goes into these considerations. So we do want to make sure that our efforts are being recognized and we are billing as appropriate.
And for folks, I'm going to just quickly clarify that for this, the way that we're using these terms are claiming, or those, and it's just for care for this discussion, are those activities that you're doing in the background, all of those administrative things that you're doing to support the care process. Yeah. And as opposed to billing, which is more of a, let's say, fee for service or direct contact, where you may be asking Medi-Cal or a managed care plan for reimbursement. And so there are trainings on that as well, and we can put those links into the Q&A or into the chat for folks. So Kate, you were starting to say about claiming earlier, and I asked you to hold off. Other thoughts? How does your county look at claiming, working with a vendor?
Deborah, which county did you say actually the audio was going in and out?
Oh, I'd just like to hear from you, how you're doing it in your
Oh.
county.
Yeah, first off, a big shout out to HMA. We used the training that you all put together on the administrative billing, sent that to our billing and benefits department, so they could understand what the expectations were. We had a bunch of meetings before we went live with our EHR team. We work on a very archaic system, which I don't think any other county works on. It's called Clinicians Gateway. And they worked hand in hand with us so billing and benefits and our EHR team worked with us to bring in the materials from San Diego, which we reviewed, made all the necessary changes to. I mean, it was a ton of work to get this done. But then we did a training on administrative billing. As we were learning it together, but we trained backs on the administrative billing procedures and the new codes that have been developed in our EHR. So we showed those and went through those together. And so, it's been an iterative process, but I think one of the best things that we did was to try and get that done as quickly as we could at the start of the program. I think we were somewhat prescient, feeling as if we were going to have a fairly quick start to this program. So I think we got that done within the first 2 weeks.
Yeah.
Everything was completed. And in our EHR, within the first 2 weeks of the necessary forms, and then about another 3 weeks later, the things like the work status report was then added about 3 weeks later to prep us for when somebody was going to have their first. Did I say work status? I meant their status report.
Their 60-day status report. Yeah.
And so how are you distinguishing an assessment activity, claiming versus billing? And that's open to the group.
Well, I think, we're really following what are the guidelines. So when you're writing the report, that's an administrative activity. When you are engaging with the client to perform that assessment and having clinical discussions, working on developing the agreement with the client and having that face-to-face with them, we're looking that as a Medi-Cal billable activity. So we're really just following the guidelines.
Great. Amber?
Yeah, absolutely. Thanks. So because that whole initial sort of investigation period is more of an informal assessment, we are claiming under the CARE activities for outreach and engagement for that. So we have our staff, although it is quite a cumbersome process, they each have an internal tracking log where they are tracking all of their claimable activities each day, which are separated into those 5 main categories of outreach and engagement, court hearing time, data reporting, notices, and report writing. I think I got them all. But so they're really tracking all of that. And then it's only when we actually are doing the more formal clinical evaluation, which in our county, we've really only done if there is still, after a thorough review of records and informal assessments, diagnostic uncertainty or eligibility uncertainty. That's when we would do that full sort of more formal assessment, and we would claim for that in the EHR. Or bill for that.
You would bill for that. Okay. Nicole?
Yeah. Amber, would you be willing to send me that internal tracking log?
Yeah, absolutely.
Amazing. Thank you.
This is the magic of these panels. Jenna?
I was going to say we built a tracking log as well that is separate from where we keep all of our notes, just so that we can track every activity. It's an Excel spreadsheet at this point, but it has some features that I've added, but it's just a really helpful tool because then, you know, we can just, and then what we are also keeping track of just so that we can look at stuff at a glance is who referred the person, because that's something we'll need to track. And then whether it's an engagement or an outreach attempt. And so we'll just have a line item for the date, what happened, you know, very briefly, like brief interaction with client, and then what type of activity it was. So it's just really easy to see how many contact points we've had. So anything that happens, whether we send a report, go to court, you know, engage with a client, it's a line item in there. So we've got a full history at a glance of how we're interacting with clients.
Oh, sorry,
Question
maybe I
is-
need to. Sorry, do you mind if maybe I need clarity then? Because we call it a huddle log, but it's very similar to an act log, and we go through that every morning. But are your internal tracking logs something that each person uses, or something that you're going through with them as a group?
We're really in early days. We haven't had a lot of petitions so far, and we have not gotten to the point of even having a care plan. So I think things are things are in motion and they're going to shift. Right now, Tara and I are just working very closely to populate the log, and you know, we have Julie and Laura, our supervisors, who are able to look at that too and see what's there. But yeah, so I think I've been adding most of the activity, but I'm also I'm the most active with care thus far. So I think it'll probably evolve as we kind of settle into what our status quo is going to be.
Oh, that totally makes sense. And Amber, was yours one that you have per staff or?
Yes. Each staff member, we
Okay,
also have legal support staff. Each staff member manages their own log, and then quarterly, they sent them all to me, and we compile them to populate the state's claimable log and submit that for reimbursement.
And I
see.
know
And then
that,
do you
that Amber will, I'm sorry, I was going to say, I know that Amber will make herself available after if there's more questions. She's been very
So
supportive
sorry,
of other. No, it's great. It's great. There's a couple things I want to make sure. It's wonderful that you're asking questions and we can continue this dialogue. I do want to make sure I hit a couple questions while we have a little bit of time. Amber, I think that's probably in your county when we're talking about folks who have not been agreeable to a care agreement, moving towards a care plan or consideration of a care plan. How has San Diego approached that and the evaluation?
Yeah, absolutely. So for us, we really don't recommend care plans. So far, all of our care participants have been care agreements. And really, it's more of, rather than recommending elevating it to a plan, which tends to damage the rapport that we've built in our experience so far, is that we continue that outreach and engagement and rapport building efforts until we can get to a place of an agreement. So that's really how our process has worked here. It would only be after we've had one instance where a care plan was sort of contemplated, and that was only after several months in a care agreement where there was limited to no progress being made, and then it was being considered to be elevated to a care plan.
Thank you. A question was asked, and I'll do this quickly before I shift, and I really want to end by talking about using trauma-informed approaches throughout this, but a question was asked, have you experienced, and what does it look like if somebody is refusing to attend court, remotely or otherwise? Folks are nodding, so you've had that experience. What do you do?
Yeah, I will say for San Diego, we definitely have had several respondents who are open to the program and the idea of it and participating in it, but they say, but I am not going to court. I am petrified of that piece. And so we use a couple different strategies, but one of the things we're able to do is if it's still clinically indicated that their participation in care, they would be likely to benefit from that, then they can waive their appearance in court to their public defender. And that is something that does happen. Sometimes, court is very overwhelming, and we have a high percentage of the individuals that we're serving through care that have justice involvement and a history of very negative experiences in a courtroom, and that can in itself can be very re-traumatizing for them. So as much as we try to explain to them that this is a court like you have never experienced before, and we are all there on your team. And just yesterday in court, we had a participant say to the judge, "Thank you for being so kind to me. I was really nervous about coming here today, and you have made me feel so much better. You have all been so kind and welcoming." And I think once a participant or a respondent can have that experience, it is so empowering and so powerful. But if they're not ready to give that experience a try, then we don't force it. We offer them alternate solutions and just try to continue to educate them on what the court experience actually looks like in care.
Thank you. We have just a few minutes left before I need to turn it back to Laura. So I would love to ask, we touched on this, starting with the person who thanked the judge. How do you embrace cultural humility and trauma-informed care when you're working with individuals and when you're doing assessments? Nicole, I'm going to start with you.
Sorry, I was having trouble finding the mouse on the screen. So yeah, I mean, I think that our biggest approach to trauma-informed care is just really, really being cognizant of where a client is at on every given day. I'm sorry, we have people, court just ended, so we might have people coming in and out of the room, so I apologize.
That's okay.
But someone said earlier that especially with psychotic spectrum disorders, people really are very different day to day. And so trauma-informed care for us so far very much looks like yesterday you were really excited about court. Last week you were excited about court. This week that sounds absolutely terrifying to you, and we'll go represent you, or we will continue the hearing or whatever is needed. If they feel comfortable doing on Zoom, we'll do it on Zoom that day. But it's really just about maintaining that rapport when it comes to trauma.
Well, and I think also that's why we approach folks with their wants versus focusing so much on their needs. It gives them agency in a way that's very different than focusing on needs. And so I think that's a big part of our focus is, on agency. And I think a great example of how we're also sort of dealing with trauma is, we have coffee every week. We have donuts for folks that come in, gift cards to thank people for coming in. They get a nice backpack with a bunch of stuff in it the first time they come to court. So I think it's, we've got flowers in the courtroom. So we've made it, we're trying to make it less of a court process and what do you want to work on? And I think that's really empowering, and we're trying to make this a much more empowering experience.
Jenna?
Yeah, I just want to echo the empowerment piece. It really needs to be a collaboration between us and the client. The last thing we want to do is walk in and give the impression that, the county thinks that you have problems and you have to get help. Like that's a terrible, obviously no one would say it just like that, but our body language and our words can really put someone on the spot, make them feel like that. So finding out what it is they need, empowering them to articulate their needs. And also sometimes like the way we're framing why we're there in the first place is that the county wants to make sure that we as health and human services are taking care of the people who live here. And so, the court's involved to make sure that we do that. And so we're really framing it in that way so that really the court's mandating that we take care of people who live here instead of the courts mandating that you show up in court. And
I think
that
that's a great reframe. Yeah,
thanks.
thank you.
Yeah, that's been working for us pretty well.
So with that, I want to thank you. I want to thank participants for joining us and choosing to spend their time with us. And I want to thank all of you for your really insightful comments.
So we hope that you got some key insights into assessment activities from these individuals who are doing this work on the ground. We wanted to point out a few resources for you. So if you haven't already, go ahead and check out our training and resource libraries on the CARE Act Resource Center. And note that our training materials have not only a recording, but also the slides. The notes have additional context and links that we reference. So if you want a deeper dive or you prefer reading, you're always welcome to go check out our training materials there. We also have a number of resources in different places on the page, including a volunteer supporter toolkit, a family resource guide, resources specific for petitioners, and then data collection and reporting guidance. We also have a county directory that lists both the county behavioral health website specific to CARE and also the court websites in each county. And we collect a number of FAQs where we add FAQs frequently to target topics that are coming up and provide some clarification. There are a number of ways that you can reach us. You can join our listserv, visit the website that we went over. You can also request deep technical assistance and specific data technical assistance as well. You're also welcome to provide feedback on the stakeholder feedback form and also send us an email at info@careact.org. We really take a no wrong door approach. So if you need help identifying resources or training or need a specific answer and you can't really find where it is, please go ahead and email info@careact.org and we'll look to connect you with the right resource. Thank you.